A 62-year-old male in the ED presents with chest pain, diaphoresis, and ST elevation on ECG. After oxygen, aspirin, and nitroglycerin, his blood pressure drops to 78/46 mm of mercury but chest pain persists. Which medication should be administered next to improve myocardial perfusion without further lowering blood pressure? A. Morphine sulfate 4. B. Dopamine infusion. C. Lidocaine 4. D. Adenosine 4. Answer, B. Dopamine can improve blood pressure by stimulating alpha and beta receptors, increasing cardiac output and perfusion. Morphine could worsen hypotension. Lidocaine and adenosine are not indicated for STEMI-related hypotension. During a resuscitation, a 54-year-old female in ventricular fibrillation has received CPR, defibrillation, and 1 mg epinephrine every 3 to 5 minutes. Rhythm remains VF. Which drug should be given next according to ACLS pharmacology protocol? A. Amiodarone 300 mg 4 push. B. Atropine 1 mg 4. C. Dopamine infusion. D. Magnesium sulfate 1G4. Answer, A. Amiodarone 300 mg 4 push is indicated for shock refractory VF/Pulseless VT after epinephrine. Atropine is for Bradycardia, dopamine is for Post-ROSC hypotension, magnesium is for Torsades de points. A patient with unstable supraventricular tachycardia, SVT, is unresponsive to vagal maneuvers and initial 6 mg adenosine 4 push. The rhythm remains narrow complex tachycardia. What is the recommended next dose? A. Atropine 0.5 mg 4. B. Amiodarone 150 mg 4 over 10 minutes. C. Adenosine 12 mg 4 push. D. Epinephrine 1 mg 4 push. Answer, C. If the first dose of adenosine, 6 mg, fails, the second dose is 12 mg rapid 4 push, followed by a saline flush. Amiodarone is for ventricular arrhythmias, atropine is for bradycardia, epinephrine is for cardiac arrest. A 48-year-old patient in Torsades de points is pulseless. After CPR and defibrillation, which drug is preferred to address the underlying cause? A. Magnesium sulfate 1 to 2G4 diluted in 10 ml D5W. B. Amiodarone 300 mg 4 push. C. Epinephrine 1 mg 4 every 3 to 5 minutes. D. Atropine 0.5 mg 4. Answer, A. Magnesium sulfate is the drug of choice for Torsades, a polymorphic VT often caused by prolonged QT. While epinephrine and amiodarone are ACLS arrest drugs, they do not correct the underlying electrolyte disturbance. A post-ROSC patient remains hypotensive despite fluids. The team considers starting a vasopressor. Which drug is first line to maintain a mean arterial pressure above 65 mm of mercury? A. Epinephrine infusion 2 to 10 mcg/min. B. Dopamine infusion 5 to 20 mcg/kg/min. C. Norepinephrine infusion 0.1 to 0.5 mcg/kg/min. D. Dobutamine infusion 2 to 20 mcg/kg/min. Answer, C. Norepinephrine is the first-line vasopressor for post-ROSC hypotension per ACLS. Dopamine is second-line. Epinephrine infusion is also an option, but norepinephrine has better survival outcomes. A 69-year-old male with acute inferior MI develops severe bradycardia, HR32, and hypotension. Which ACLS medication is most appropriate initially? A. Atropine 0.5 mg 4. B. Adenosine 6 mg 4. C. Epinephrine 1 mg 4 push. D. Amiodarone 150 mg 4 over 10 minutes. Answer, A. Atropine 0.5 mg 4 every 3 to 5 minutes is first line for symptomatic bradycardia, up to 3 mg, adenosine is for SVT, epinephrine 4 push is for cardiac arrest, not bradycardia. A patient in the ICU develops symptomatic bradycardia unresponsive to atropine. Which is the preferred pharmacologic option before transcutaneous pacing? A. Dopamine infusion 5 to 20 mcg/kg/min. B. Lidocaine infusion 1 to 4 mg/min. C. Magnesium sulfate 2G4. D. Nitroglycerin infusion 10 to 200 mcg/min. Answer: A. Dopamine infusion can increase heart rate and blood pressure when atropine is ineffective in bradycardia. Lidocaine is for ventricular arrhythmias, magnesium is for torsades, nitroglycerin would worsen hypotension. A 45-year-old patient in septic shock is receiving norepinephrine but remains hypotensive. Which medication may be added to improve vascular tone? A. Atropine 1 mg 4. B. Amiodarone 300 mg 4. C. Vasopressin 0.03 units/min. D. Diltiazem 0.25 mg per kilogram 4. Answer: C. Vasopressin may be added to norepinephrine for refractory hypotension in shock states. Amiodarone, atropine, and diltiazem are not indicated for septic shock vasopressor support. A patient with a history of atrial fibrillation develops rapid ventricular response despite beta-blocker therapy. Which ACLS drug is preferred for rate control in this scenario? A. Amiodarone 150 mg 4 over 10 minutes. B. Epinephrine 1 mg 4 push. C. Lidocaine 1 to 1.5 mg/kg 4. D. Atropine 0.5 mg 4. Answer: A. Amiodarone is effective for rate control in atrial fibrillation when beta blockers are ineffective or contraindicated. Epinephrine and atropine are not for AF, lidocaine is for ventricular arrhythmias. A 50-year-old patient in ventricular fibrillation receives epinephrine and amiodarone. ROSC is achieved, but blood pressure remains 82 over 50 mmHg despite fluid bolus. Which drug is preferred? A. Procainamide infusion. B. Nitroglycerin infusion. C. Adenosine rapid 4 push. D. Norepinephrine infusion. Answer: D. Norepinephrine is first line for post-ROSC hypotension to maintain perfusion. Nitroglycerin could worsen hypotension, adenosine is for SVT, procainamide is for arrhythmias, not hypotension. A 68-year-old male with a history of heart failure presents with sudden onset palpitations and chest discomfort. ECG shows monomorphic ventricular tachycardia at 150 bpm, BP is stable, and oxygen saturation is 96%. Which pharmacologic intervention is most appropriate? A. Amiodarone 150 mg 4 over 10 minutes. B. Adenosine 6 mg rapid 4 push. C. Epinephrine 1 mg 4 every 3 to 5 minutes. D. Lidocaine 1 mg per kilogram 4 bolus. Answer: A. For stable monomorphic VT with adequate perfusion, amiodarone 4 is recommended for rhythm control. Adenosine is used for certain SVTs, epinephrine for cardiac arrest, and lidocaine is a secondary alternative. A 45-year-old woman collapses in the emergency department. The monitor shows pulseless electrical activity, PEA. What is the most appropriate first pharmacologic intervention after initiating CPR? A. Atropine 1 mg 4. B. Epinephrine 1 mg 4 every 3 to 5 minutes. C. Amiodarone 300 mg 4 bolus. D. Magnesium sulfate 2G4. Answer: B. For PEA, epinephrine is the drug of choice along with high-quality CPR. Atropine is no longer recommended for asystole or PEA. A patient with suspected inferior wall MI develops bradycardia with a heart rate of 35 bpm and BP of 80/50 mm of mercury. Which medication is indicated? A. Adenosine. B. Atropine. C. Amiodarone. D. Dopamine. Answer, B. Atropine is the first-line drug for symptomatic bradycardia. If ineffective, dopamine or epinephrine infusion may be used. During a code, a patient is found in ventricular fibrillation. After one shock and CPR, the rhythm persists. Which medication should be administered next? A. Amiodarone 300 mg 4. B. Lidocaine 1 mg per kilogram 4. C. Epinephrine 1 mg 4. D. Magnesium sulfate 2G4. Answer, C. Epinephrine is given after the first shock during persistent VF or pulseless VT. Amiodarone is given after epinephrine if VF/VT continues. A 60-year-old postoperative patient suddenly develops rapid narrow complex tachycardia at 180 bpm, is stable, and is on continuous ECG monitoring. Which drug is most appropriate? A. Amiodarone. B. Adenosine. C. Epinephrine. D. Atropine. Answer, B. Adenosine is the drug of choice for stable supraventricular tachycardia, SVT, due to its rapid onset and short half-life. A patient in the ICU develops torsades de pointes on the monitor. Which medication is most appropriate to administer? A. Amiodarone. B. Lidocaine. C. Magnesium sulfate. D. Adenosine. Answer, C. Torsades de pointes, a polymorphic VT often caused by prolonged QT, is treated with 4-magnesium sulfate. A patient with symptomatic bradycardia does not respond to atropine. What is the next recommended pharmacologic option? A. Dopamine infusion. B. Amiodarone bolus. C. Adenosine. D. Lidocaine. Answer, A. If atropine is ineffective, dopamine or epinephrine infusion is used to increase heart rate. During resuscitation, a patient in persistent VF has already received epinephrine and a shock. What is the next drug intervention? A. Magnesium sulfate 2G4. B. Amiodarone 300 mg 4 bolus. C. Atropine 1 mg 4. D. Adenosine 6 mg 4. Answer, B. Amiodarone is given for refractory VF after epinephrine and defibrillation. A 55-year-old patient is experiencing unstable atrial fibrillation with RVR and hypotension. The patient is in the ICU with 4 access. Which pharmacologic approach is most appropriate before synchronized cardioversion? A. Amiodarone infusion. B. Adenosine bolus. C. Epinephrine. D. Immediate lidocaine bolus. Answer, A. Amiodarone can be given to attempt rate/rhythm control before electrical cardioversion in certain unstable AF cases. A patient with a history of asthma is in cardiac arrest with asystole. Which drug should be avoided due to bronchospasm risk? A. Epinephrine. B. Amiodarone. C. Lidocaine. D. None of the above. Answer, D. Epinephrine is necessary in asystole and is safe even in asthma during arrest. No ACLS drug is contraindicated in this setting. A patient in septic shock remains hypotensive despite fluids. BP is 70/40 millimeter of mercury, HR is 110 bpm, and oxygen saturation is 92%. Which pharmacologic agent is first line for vasopressor support? A. Epinephrine infusion. B. Dopamine infusion. C. Norepinephrine infusion. D. Vasopressin. Answer, C. Norepinephrine is the preferred first-line vasopressor in septic shock due to its strong alpha effects and limited beta effects. A patient post-cardiac arrest develops bradycardia at 40 bpm with confusion and hypotension. Atropine fails. Which drug is recommended next? A. Epinephrine infusion. B. Amiodarone. C. Adenosine. D. Lidocaine. Answer, A. Epinephrine infusion is a second-line treatment for symptomatic bradycardia unresponsive to atropine. During ACLS, a patient develops severe hypotension and wide complex tachycardia. Which drug should be avoided due to risk of worsening hypotension? A. Amiodarone. B. Lidocaine. C. Procainamide. D. Adenosine. Answer, C. Procainamide can worsen hypotension, especially in unstable patients, so it should be avoided. A patient with narrow complex SVT is given adenosine but develops transient asystole for 5 seconds before returning to sinus rhythm. What is the correct interpretation? A. Adenosine overdose. B. Expected transient effect. C. Myocardial infarction. D. Electrical conduction block requiring pacing. Answer, B. Adenosine briefly blocks AV conduction, which can cause transient asystole before normal rhythm resumes. A patient in VF arrest has already received epinephrine and amiodarone without conversion. What is the next pharmacologic consideration? A. Lidocaine bolus. B. Atropine. C. Adenosine. D. Dopamine infusion. Answer, A. Lidocaine can be used as an alternative antiarrhythmic if VF persists despite amiodarone.